So we're going to go ahead and get started. This is being recorded. So I want to welcome everybody and let you know that because it's recorded, we want to keep everybody's information private. So the only way to ask questions is to use the Q&A box that is down below next to the participants option there. So just type your questions in there. I will get them and be able to ask Jessie here. So I want to just start by saying thank you so much for joining us. My name is April Rutter. I am the co-founder and COO of HeraFertility. We're a digital first fertility solution trying to help give affordable and convenient fertility care to those who are trying to conceive by using virtual visits and using medications that can be delivered at home and using really our care teams that can work one-on-one with patients in numerous ways of being able to communicate with them in real time and help them through their cycles. One of those clinicians that works with our patients is Jessica Smith. She is a nurse practitioner that has been in the fertility field for 10 years, right? Getting close.
Close to that, yeah.
Yeah, you're getting close to your 10 years. So I appreciate you for taking some time out to join us and help people who may have some questions on really, what they can do in their own fertility journey in order to increase their chances or what they should be looking at. I mean, there's just so many questions behind fertility. And so we just wanted to give them an outlet where they really felt like they could bring their questions, get real answers, and try and help people in their struggle with fertility. So with that being said, I'm going to give you a minute to kind of introduce yourself a little bit more, and then we'll jump into these questions.
Okay, great. Yes, thank you, April. I'm like April said, I'm Jessica Smith. I am a women's health nurse practitioner. My whole career has been working in women's health. I've like April said, the greater of the past 10 years, I've had a focus in reproductive endocrinology, working with couples who are trying to conceive. I definitely have a passion for that. So I'm happy to be here. Happy to help in any way I can.
Nice. Okay, so I'm going to start with some of the questions that we got prior to the start of the webinar, and then we'll be able to get to the questions that are being added through the Q&A box at the bottom of the screen. So I thought this one was interesting because we do see so many people with a diagnosis of PCOS. And this one says, I have PCOS. What are my options? Should I just try on my own, or, definitely make an appointment with a fertility specialist? What would you say they should do if they know they have this diagnosis?
Yeah, it's a good question. PCOS is a little tricky, but the reason why there's an association with PCOS and infertility is because often women with PCOS will have a ovulatory dysfunction or anovulation, meaning that they don't ovulate on their own, or they don't ovulate in a consistent, regular way. And so certainly if we know that there's that underlying diagnosis, there are definitely things you can do on your own to kind of try to help manage that in the best way you can, as far as just like your lifestyle, diet, trying to treat or manage maybe some insulin resistance that can be associated with that. So, I mean, there's certainly some things that you can do on your own. However, I would say that if you have PCOS and your main goal or primary goal is to have a baby, and you're not having a regular, consistent ovulation, I definitely would encourage you to seek an evaluation and treatment, because in order to have a chance of being successful conceiving, you have to be able to ovulate, and so without that, um, it would be difficult to be successful on your own.
So you had mentioned, lifestyle changes and diet with PCOS patients. It kind of bleeds into another question that we got. It says, I've read a lot about the impact of diet on fertility. From your experience, do you have any tips on specific foods or nutrition plans that you would recommend to boost fertility?
So, I'm not a nutritionist, um, but I do, feel like diet plays a role in your reproductive health. I tend to recommend just a balanced diet, that's really rich in fruits and veggies, whole grains, lean proteins, healthy fats. I would, try to, especially in women with PCOS, I would try to minimize the processed foods, things that we know can kind of increase inflammation, and just overall trying to maintain a healthy weight, when it comes to your reproductive health. Too little weight and excess weight certainly can be a factor. But I don't necessarily have a specific diet that needs to be followed. Just try to be as balanced and healthy as you can.
Okay, and so we do have a question here that says, I'm a single woman, 34 years old, no plans to have kids yet, but I'm interested in having kids in the future. Would you recommend egg freezing? And what's the latest age that it would still be viable to freeze my eggs? In addition, what can I be doing now to optimize my health for later fertility, whether it be supplements, diet, lifestyle, those kinds of things?
That's a great question. And I'm glad someone asked because I feel like, there's many that might find themselves in that situation. Um, when it comes to your fertility or your reproductive health, one of the big pieces of that is our ovarian reserve or egg quality, egg quantity. And there's a couple of ways that can be assessed. So definitely, as we get later into our 30s, and if you're thinking about your reproductive health, or thinking that you may want to try to start a family, that may be something to have evaluated to kind of see where you're at currently. The hard thing is we anticipate that our ovarian reserve, our egg quality, our egg quantity, we anticipate that declining or diminishing as we get older. And it's different for everybody, but kind of statistically speaking, we'll start to see that around the age of 35. And at what rate that's going to decline is hard to say. So it is difficult, when assessing. Unfortunately, there's no test that says like, okay, we can check your egg quality or your egg quantity today, but that doesn't tell me what it's going to be like in 6 months or a year from now, so that does get very challenging. When it comes to egg freezing, there is not a whole lot of data on the success of egg freezing after the age of 35. So, for this person in particular at age 34, if that's something that um, um, you're serious about, I definitely would consider talking to someone, or seeking an evaluation and kind of seeing what your options are there, just because we don't have a ton of data on what that looks like after the age of 35. And certainly, the older we get, the more um, barrier we have to that. So yeah, I definitely would. Did I answer each piece of that question?
Yeah, I think
Okay.
the only other part is there anything that she can do in order to optimize fertility through supplements, diet, or lifestyle?
So, I mean, kind of again, just as far as um, your reproductive health, as far as things you can do on your own, just kind of a healthy, balanced diet. I mean, there's not anything in particular that I would suggest food wise. Saying um, you want to try to maintain a normal weight. Um, you want to avoid substances, any sort of toxins like tobacco, excessive alcohol, any drug use. I mean, those sort of things can certainly have a negative impact. So those are kind of the big factors in terms of just kind of your lifestyle and such that potentially could have a negative impact.
All right, and you had mentioned being able to evaluate ovarian reserve. Can you go in a little bit deeper on what tests those are that they're going to perform in order to evaluate that?
Yeah, sure, sure. So, when talking about ovarian reserve, I'm referring to the quality and the quantity of your eggs, and in some ways, maybe you can separate the two because those are two different things. But generally speaking, they go hand in hand, and kind of as the number of eggs that we have left decrease, so does the quality of them typically. There's a couple of ways that can be evaluated. One, by checking some hormone levels. Some of which need to be done during a certain time in your cycle. There's another marker that's called your AMH or your anti-Müllerian hormone level that can be checked at any time in your cycle, and that is one of the ways that we can assess that. Also, by doing a pelvic ultrasound and looking at the appearance of the ovaries, you can look at the size of the ovaries and the number of follicles in the ovaries, and that can give us an idea. And then age is probably the biggest predictor of our reserve. So, we just know that as we get older, we anticipate our reserve or our egg quality, our egg quantity diminishing. And it doesn't mean that you can't have a baby at a certain, as we get older. It just kind of tells us like, generally after the age of 35, that's going to be something that you're up against.
Okay, and I know you mentioned doing the ultrasound. That kind of brings us into our next question here that says, since Hera is meant to primarily be online and through telehealth, how do we go about some in-office fertility testing like HSG, saline sonohistograms, and ultrasound monitoring? So can you talk a little bit about how that relationship works with the outside groups we use for those things?
Yeah, so I mean, just kind of as if you were in office. With Hera, we meet initially, uh, go over history and such, and then from there, kind of recommend a testing or an evaluation. As far as those tests that need to be done in an office somewhere through Hera, they can still be ordered, and then it's often April. You're the one helping facilitate that. Whether it's at their local office or at an imaging center or um, you know uh, lab facilities or at home kits. I mean, there's a couple of different options there. And then we get those reports. There is some limitation, I would say, to not really being able to see or not being the one performing. It's a lot of just taking the interpretation, but we're still able to use that information and provide recommendations.
Yeah, I mean, I think the important thing is we're able to really utilize their situation. So I know, once you decide, hey, we need to get something like an ultrasound performed to evaluate the uterus and the ovaries and make sure that there's nothing deeper going on. I'm able to talk with the patients and figure out, maybe they have an OBGYN that they just love seeing, and I can call that office, make sure that they, are comfortable performing these kinds of ultrasounds. If they don't have anyone that they already use, then we can really price shop it for them if price is the most important thing to them. So we can really individualize this to make it exactly what the patients are wanting. So we are able to use our network of partner clinics and other facilities that are close to the patient, take the patient's insurance, or have the cheapest self-pay price. So yeah, that is how we do that. I hope that answers that question. Now we're going to move on to the next question here. So it's kind of a two-part question. They would like to know your view on CoQ10 and also the effect on getting pregnant after being pregnant and breastfeeding. How much can breastfeeding delay menstruation?
Okay. So CoQ10 is a supplement that generally I do recommend to patients when we have concerns about diminishing egg quality, egg quantity. There's been some pretty good studies that show that it can be helpful in women with diminished ovarian reserve who undergo IVF. The studies kind of show they increase the number of mature eggs that have been retrieved. And so with that, even without IVF, certainly I do tend to recommend it as a daily supplement anytime there's potential concern for diminished reserve. I think it is most beneficial if has been taken for like 3 to 6 months. Probably it's not a super like fast acting thing, but yeah, I do think it can be helpful. Um, the next question was breastfeeding, you said?
Yeah, how much
Um,
can it delay menstruation? And, what are the kind of the effects of getting pregnant again after you've just, been pregnant and you're still breastfeeding?
mhm. So, breastfeeding, the reason why it can, have an impact on menstruation is because it with breastfeeding your hormone called prolactin is really elevated, and when your prolactin level is really elevated, that disrupts the ovulatory cycle, and when you don't ovulate, you don't get a period. And so that is why you'll see many women who are breastfeeding won't get a period, or their period isn't super consistent because it's typically like preventing that normal ovulatory cycle. Now it is different for everybody. Many women, maybe for the first 6 months they breastfeed, and especially if they're exclusively breastfeeding and they're not getting a period, that tells us that they're likely not releasing an egg. After that, sometimes, while you're continuing to breastfeed, your period will resume. So it's as long as you get your cycle again, that tells us that ovulatory function is happening again. Now I would typically say that if you're done breastfeeding and you still haven't gotten a period for like 3 months after you stopped breastfeeding, then that would warrant an evaluation. I mean that but otherwise, it's not uncommon the whole time you're breastfeeding for you to not have a period, or sometimes it will start to return, maybe if it's been more than 6 months, and maybe you're not exclusively breastfeeding or breastfeeding as like frequently.
Okay, this next one is interesting. I can't wait to hear to hear the answer to this. Is there any research done on ovarian rejuvenation? If I'm older and already pregnant but want to have more children, should I save the umbilical cord, placenta, and any cord blood to help with ovarian rejuvenation? If this is even something it can be used for,
That is an interesting
right?
question, and I don't know if I have a great answer for it. I think the ovarian rejuvenation, there is, some some things out there on that. And it will be interesting, I think, to see over time, maybe what we learn and what things are possible. Currently, to my understanding, there's not really good evidence on it. So I can't really say that there's anything that I would recommend or that we really know a whole lot about. But it will be interesting to kind of see what the future holds in that, I guess. Um, I don't, what was it about, the
To
umbilical
save the
cord?
umbilical cord, placenta, or any cord blood to help with ovarian rejuvenation?
Um, to my knowledge, and I don't know that that would be helpful. 'Cause it will be interesting to see, but I don't think there's any evidence to really support the need for that.
I Our field is constantly growing and it moves so
Yes.
fast. So I will definitely take this question back to some people I know at the American Society for Reproductive Medicine and see if I can get some information on what's coming out that maybe hasn't been published yet. And we'll definitely share anything that we find on the follow-up emails. So, because
Yeah,
yeah,
that
I
would be
mean, I
great. And
absolutely
yeah,
want to know more.
yeah, share with me too, April, because it will be interesting to kind of see. I just, to my knowledge, I'm not aware of anything.
Okay, so the next question is for someone who's in the midst of the IVF process, what is the more optimal time of the day to do monitoring ultrasound and blood work? Also, is there a difference if the meds are injected in the stomach versus the upper thigh or buttocks?
Um, I don't think the time of day when you're getting, when you're going through IVF, the time of day for the ultrasound monitoring and blood work, it doesn't necessarily matter much. I think it's more so just kind of when you're comparing value. So like if you were to do one appointment, say like late in the afternoon, and then you were to do the next appointment like the following morning, that's obviously, less time between than if you were to do like one appointment first thing in the morning and then the next appointment first thing in the morning. So you want to just kind of look at comparison, like how much time has passed. But as far as monitoring and such for ultrasound for follicular development and hormone levels to assess like your response and the stimulation protocol, if that's what we're referring to, then the actual time doesn't really matter. As far as the injection sites, if you're referring to like the stimulation medicines, like while like prior to egg retrieval, um, it's a subcutaneous injection, so meaning it's just going underneath the skin. So it really can be given either in the abdomen or the thigh. The buttocks would only really need to be if it were an intramuscular injection. I usually do recommend the abdomen just because it's easier access that way for the subcutaneous injections.
Okay. And then, so where does someone get an ovarian reserve test and hormone test done? Can you go to your gynecologist? Because this person is saying that their gynecologist doesn't do any of these tests.
So it does depend on the comfort level of your gynecologist. Some feel comfortable ordering those labs and some don't. I would also say that it is important to you want somebody ordering those labs who feels comfortable interpreting the results. I will tell you, before I worked in infertility, I worked at an OB/GYN office. My whole background was in women's health and OB/GYN, and I thought I had a decent understanding, and then I start working in infertility. I'm like, oh my goodness, I didn't know what I didn't know, basically, and there's many OB/GYNs that are, more than qualified and feel more than comfortable ordering those labs and interpreting those. But I would say if they don't, I would seek somebody who does, whether that's a fertility specialist or some online platforms. There certainly are options there, but I would encourage going to someone who's comfortable ordering the labs and comfortable interpreting those results.
Along that same line, this person is saying that they've been told by their doctor that they can't have their fertility tested. They're wondering if that's true, and they're a little bit worried if they don't get tested because they're just starting to try.
Okay.
So can you think of a situation where you just couldn't test fertility?
Well, I mean, I think that maybe what they mean by that is there unfortunately is no test that says like, oh yes, you definitely can have a baby, or no, you can't, right? So there it is not a clear assessment, or there's not just a one, a straightforward answer to that. So maybe that's what they mean by that, as far as like there's no way to say for sure yes you can, or no you can't. Um um but I mean, there certainly are assessments that can be made. You can take little pieces of information and make your best assessment. And we can certainly look at things that we know have an impact on your fertility, and um, rule out things that we that to make sure that we don't see anything abnormal or unexpected. And then if everything looks good, especially if it's something that you're just trying, or just considering, um if everything checks out, then you don't have to worry about, I mean, then you can just kind of continue to try on your own, type of thing, I guess is what I'm saying.
Yeah, I mean,
um
I think my only thought when I read that question was it's possible that they were saying they couldn't do the fertility testing because the insurance wouldn't pay for it. If you're just starting out, sometimes insurance, may require certain things in order for you to use your coverage. But just because you can't use your coverage doesn't mean you couldn't get tested for something. If, you know, there are other things, there are other diagnosis codes. Sometimes you're having symptoms that would allow for certain tests, maybe not all of them, but some of them. So, I mean, it really kind of depends on the situation. So I would be kind of interested to see if maybe it was a concern for it being covered. But I do know a lot of people
Mhm.
that even if their insurance won't cover it, still want the information in order to feel like they can move forward and feel like they're successful and there isn't anything blocking them from getting pregnant. Uh, this next question is, can you still get pregnant with frozen embryos if you are perimenopausal or menopausal?
Yeah, that's a great question. And yes, um you can. It you would need to do what's called kind of a controlled frozen embryo transfer cycle, or a medicated frozen embryo transfer cycle, where you use medicines to prepare the uterus for an embryo transfer. But yes, it definitely, your ovaries don't have to be functioning in order to be successful with an embryo transfer.
This question is, if you want to freeze embryos, then how long after breastfeeding should you start? Also, um, I'm not going to say this word right either. She says she probably spelled it wrong, but I'm not going to get it right. Um, Ubiquitol, Ubiquitol. I'm guessing it's a supplement.
Oh, like ubiquinol?
Sure, that sounds great. Versus actual CoQ10. And in the same line of thought about prolactin, if there remains a high level in the body, does a prolactinoma prevent ovulation? And she did say she
Okay.
was sorry for all the questions, but you never
Hey,
have to be
that's
sorry. We want questions.
Yeah, no, that's great. Let's start with the first one. What was
Yes.
that?
If you want to freeze embryos, then how long after breastfeeding should you start?
To like make embryos to freeze them. Uh, there's different thoughts on this for sure. Sometimes if you're still breastfeeding, that certainly can kind of impact your response to like an IVF cycle. If we're going to freeze embryos, that means we have to go through an egg retrieval. We have to stimulate the ovaries to make eggs and put sperm with eggs to make embryos and then freeze them. Ideally, I would tend to recommend not to do that while you're breastfeeding, and then maybe even a couple of months since you've stopped breastfeeding, just to um, try to optimize your response to the IVF cycle, to the stimulation cycle. I don't know that there's really a clear cut, like you must wait this amount of time, but usually, just to eliminate any barriers or to try to optimize your response, I would recommend waiting a couple of months once you're done breastfeeding.
So, on that same note, I know that there are some clinics that have you go through some testing and some things before you can get started on your cycle. Now, would they be able to do that in the months that they're waiting between stopping the breastfeeding and getting started, so that way they can still get that stuff done?
Yeah, I would say so. I would say so for sure. Yeah,
Okay,
yeah.
and so now it's the Ubictol versus
Ubiquinol.
CoQ10.
Uh-huh. Well, so yeah, and I'm not a nutritionist, so but I generally do recommend CoQ10 and the form of ubiquinol. It's a form of CoQ10, and that seems to be the most helpful in women with diminished ovarian reserve. So that ubiquinol is the type of CoQ10 that I would recommend.
Okay, and with high levels of prolactin in the body, does a prolactinoma prevent ovulation?
It definitely can. Not everyone with a prolactinoma, which is a small little pituitary tumor. So your pituitary is in your brain, and it's a tumor on the pituitary gland that releases or secretes prolactin. That's what a prolactinoma is. And it certainly can, especially if big enough or releasing enough prolactin, that certainly can disrupt the ovulatory cycle.
Okay, and this next one I'm actually going to answer because this is, she says, I have progeny through my employer. Should I call them when I need to see a fertility doctor? They should cover everything. Yes, you absolutely want to call your patient advocate through your progeny, so that you can let them know kind of what you're thinking, where you're at. They'll be able to tell you all of your smart cycles, which is, kind of their way of processing things. They give you so many smart cycles, and depending on your treatment, then it takes up, either half of a smart cycle or one and a half smart cycles. So definitely reach out to them, let them know what you're thinking, and but just know that you have the ability to say yes or no. Um, they can tell you what's covered, but they can tell you who's going to be covered. But if they're trying to push you in one way or the other, just know that you can say yes, that's the clinic I want, or if you know of another clinic that's also in network, you have the flexibility to stay within the network and see anyone within that you'd like. And it's okay to get a second opinion. So if you ever wonder what they've been saying or what that means for you, and should you take that advice or not, you can always reach out to us and bounce those ideas off of us. I have worked with Progeny for a long time, and the coverage and what they're doing is really amazing. So I would say take full advantage of it, absolutely. But just know that you're not boxed in. You can still have control of your fertility journey. Um, okay, so the next question is, at what point in the fertility journey do you recommend surrogacy? and on which type of situations?
So, by surrogacy, generally what people are referring to as using a gestational carrier, which is where you have an egg source, whether that's your own eggs or donor eggs, and then a sperm source, again, whether that's your partner's sperm or a donor sperm. But you make an embryo, and then someone else carries that embryo. That embryo is transferred into a third party's uterus. So that third party is generally referred to as the gestational carrier. And there can be a number of reasons why someone might um, consider using a gestational carrier or may need to use a gestational carrier. Certainly, if you yourself, if you don't have a uterus, or sometimes if there is significant uterine malformation that makes it seem like carrying a pregnancy yourself is going to be too difficult. Sometimes then the option of using a gestational carrier is available. Um, Sometimes if just your health, if for whatever reason you have a health condition that maybe requires certain medication or treatment that isn't compatible with pregnancy, that sometimes leads down the pathway of using a gestational carrier. um, Sometimes, if there's been recurrent pregnancy loss or recurrent implantation failure, some situation like that where the thought of using a gestational carrier is brought up to see if that potentially increases chances of being successful. So there's a number of different um, things that lead to that. But it is an option available for a variety of reasons.
Can a prolapse of any kind affect your ability to get pregnant either naturally or through IVF, or stay pregnant despite the mode of conception?
Mm, so it's not a common cause of infertility, I would say, but I mean, certainly if there's a complete prolapse, I mean that potentially, would have some impact on fertility. Um, and then sometimes, there's an association with a prolapse. I'm thinking that we're referring to a uterine prolapse. Of course, there's um, bladder prolapse or vaginal wall prolapse. But if we're referring to the uterus, sometimes just intercourse, that can be difficult, and so that's something that maybe needs to be addressed. But I would say that no, I mean just having that history, or if there's a mild or moderate prolapse, I wouldn't really anticipate that being a big concern in your reproductive health.
And for context, can you just kind of explain what a prolapse is?
Well, prolapse is kind of weakening of the walls, so like weakening of the pelvic floor muscles that causes the organs to kind of uh, um, fall, or kind of not stay in their original spot. And so that can be just from the vaginal walls, it can be the uterus, it can be the bladder. Um, and so it generally um, we see prolapse with a history of pregnancy, and especially large birth weight. You'll see an increased risk for prolapse, and just as we get older, there's an increased risk for that. But of course, it can help happen, and women of reproductive age. Definitely pelvic floor therapy. I would strongly encourage to consider if that's something that you're worried about. Seeing a pelvic floor physical therapist would be probably the first thing I would suggest.
Okay. This next question is, what is letrozole and how does it help with fertility? I heard about it from a friend of mine.
Oh, so letrozole is an oral medicine. It's a what's called an aromatase inhibitor. So it works by decreasing your estrogen levels. And um, as it decreases your estrogen levels, that low estrogen level stimulates a hormone in your brain to release more FSH, which FSH is a follicle stimulating hormone. And that, so that causes your follicles to grow and hopefully release mature eggs. So it helps with ovulation. um, and so definitely in someone who doesn't ovulate at all or doesn't ovulate consistently or in a regular manner, I mean, it can be very helpful in correcting that. It can be used outside of even if in someone who does ovulate normally, it can be helpful, especially if paired with like insemination or during IVF. It can be used for that as well.
Okay, and if you don't have diminished ovarian reserves, can CoQ10 somehow negatively affect your supply? And I would also add, is it helpful? If there is no diminished ovarian reserve, does it help or harm to take CoQ10?
Um, I would probably say it doesn't harm anything. I don't know of any reason why it would be harmful, but I don't know that it would be that beneficial either. I mean, there's a lot of different reasons people take CoQ10, so there would be nothing wrong with doing it, but I just don't know in terms of um if there's not a concern with diminished ovarian reserve, I don't think CoQ10 is going to impact your fertility otherwise.
Okay, and then let's see, this one says, is there any clinical difference in doing back-to-back cycles versus spacing them out a little bit?
Um, Back-to-back cycles as far as like ovulation induction or IVF, I wonder.
Yeah,
Um,
there isn't specification on that, so
okay,
maybe
I'll
speak to
speak
both.
to Yeah. As far as ovulation induction goes, meaning like taking letrozole or Clomid to help induce ovulation, it I think there is actually some benefit in doing like a back-to-back cycle. I don't know how much evidence really supports this, but I just from experience, working with patients, we will see often that, especially in someone who doesn't ovulate normally, maybe trying one ovulation induction cycle, if not successful, or, sometimes they have a hard time really responding to it. And then, if not successful, try or once we get you to respond, then if you try right again, we tend to have a better response or even sometimes a over response. So I think there is definitely something to doing those ovulation induction cycles back to back. As far as IVF, I don't know that that's really the case. It would kind of depend on what back to back is. I think that if you do a stimulation, IVF egg retrieval, and then you stop all your medicines, and with that next period go right back into one. I don't know that that's necessarily a pro or con to that.
Okay, this one says, as someone who's just starting to explore fertility treatments, the information out there can be overwhelming. What are the most important factors that I should consider when choosing a treatment path?
Yeah, it can be very overwhelming for sure, for sure. There's a lot of information out there. Um, I would say, initially, if you're just kind of trying, or if you're just starting to explore fertility, whether that means, you've been trying for a while and haven't been successful, or you're kind of early and trying, I definitely would kind of first look at um, just what's going on with you personally, and with your partner, kind of basic things as far as like, are you getting a period each month? Are you timing intercourse? Are you having any trouble with intercourse? Those type of things, I would kind of just look at first. Um, as far as, I mean, a treatment path, I mean, generally, I would recommend talking to somebody, talking to a fertility specialist, kind of breaking it down into, what's going on with you as the individual, what testing options are available to kind of see if there is a infertility factor going on, if there's a barrier to why you haven't been successful, or kind of having some of that evaluation done, because often that guides kind of the treatment path for you. Or if everything kind of checks out and you want to just continue to try on your own, there's nothing wrong with that. But if in that evaluation, you find that there's a um sperm count issue, or there's something wrong with your tubes, or something that kind of helps guide what treatment path would be recommended.
Okay, and it looks like we have someone who has raised their hand, and I don't know that we have a way for you to verbally speak your questions. So definitely type out your question in the Q&A box that's next to your, it should be in between maybe the chat and the participants. That's where mine is. But if you can put your question in there, I'd love to be able to get to it so Jesse can answer it for you. So this next one is, I'm considering undergoing fertility testing, but I'm a bit scared of what I'm going to find out. What would you say to someone who's feeling anxious about starting this process?
um yeah, it certainly can be scary, for sure, for sure. um I would say that generally information is good to have. So even if it's scary, even if it's um not information you want to hear or expect to hear, it's generally better than not knowing, because with that information, then you can kind of make a more informed decision moving forward. I think that it is scary, and I mean, I totally understand that. Um, um, but I do think that any information that you get can be helpful. And then I think part of why it's so scary is the unknown. You wonder, and so I think little bits of information would be helpful.
Yeah, I think that the one thing I heard the most when talking with patients was just that they were worried about hearing that they weren't going to be able to have the family that they wanted. But even the patients that got news that said, "Hey, you're not going to be able to have a completely biological child between the two of you," um, they tend to have felt better to be able to hear that, to grieve it, and then still be able to see that there are other options. There are other things, and knowing how you can build your family is a success in my book. Like that's the step that you need to take in order to really be able to have all the information and make the right choices for you. And if you don't have that information, it can make this process a lot harder and a lot longer. So yeah, I think that it's important to get all the information that you can. But it is something that you have to be prepared for and dealing with some of that anxiety and some of the hard talks, between you and your partner. Sometimes couples will go to a mental health professional in order to prepare themselves for those, instead of waiting until they get the information, then going and seeking help. They'll kind of prepare themselves beforehand. So I think that if you're having anxiety, you should definitely do something and talk to someone to be able to deal with that. Um, so the next question here is, can you explain the difference between the basic fertility tests and when someone might need more advanced testing or procedures, I
Okay.
guess, because some
Yeah.
of those tests are procedures.
Yes. Yes. Um, I would say basic fertility testing. I would break it down into, kind of looking at what we need to have a baby. And To kind of try to simplify that. I mean, it is, I think, maybe a little more complex than this, but to start to break it down, I would look at sperm. I would look at the uterus. I would look at the tubes, and I would look at eggs. And so as far as basic testing goes, with sperm, I would recommend a semen analysis. Now, if that semen analysis is normal, then we don't need to do necessarily any further testing or workup all the time. So as far as like basic versus advanced, if that basic initial test is normal, then you may not need to consider any further testing as far as sperm goes. Um, Kind of the same thing with the uterus. If you have an ultrasound done that looks at the size and the shape of the uterus and, looks to see if there's any like abnormal growths or fibroids, make sure that there is not any anomaly like being born with like half a uterus or two uteruses or something like that. Generally, those things can be caught on just a basic pelvic ultrasound. Now, if the ultrasound kind of shows something that is abnormal or requires further evaluation, then that's when you may need to do further testing, like further imaging or a saline test to look inside the uterus, or have a hysteroscopy where they actually take a camera and look inside the uterus, like those sort of things. But if that ultrasound looks pretty good, it doesn't show any signs of concern, then you probably don't need to look any further as far as the uterus goes initially. Um, Tubes, generally there's a couple of ways to evaluate the tubes. Probably the most common is an HSG or a histosalpingogram. Now that is somewhat of an invasive test. It's not fun to have done generally, but it lets you know about the tubes. Make sure that they're open, that they don't appear diseased or dilated, and then it also gives you an idea about the inside of the uterus. So it's kind of a 2-for-1 test. Again, if something's abnormal from that, maybe that will require a laparoscopy where they actually go in and look at the tubes. Um, um, but usually if that initial test looks good, you don't need to do any further testing. Um, and then kind of same with eggs. I mean, I mentioned earlier about the different ways that you can look at eggs. Maybe just getting some basic blood work, looking at how the ovaries look on ultrasound. That is generally what's needed. Now, sometimes if those things come back abnormal, especially for younger women when it's not expected, then sometimes that warrants further investigation to see, why is this happening in someone who is younger, that we wouldn't anticipate that happening. So there certainly is a difference, but usually that basic workup, if everything kind of checks out there, then you don't necessarily need to do any further testing.
Okay. So this one here says, I've been hearing more about endometriosis. How would I know if I have endometriosis? And with this question, I would love if you'd go into a little bit about how it's so misdiagnosed and what the last average was like 5 or 10 years before someone gets diagnosed correctly with this. So this is a really big problem. So can you kind of delve more into the endometriosis conversation?
Yeah, sure, sure. So endometriosis is a condition where endometrial-like cells, so the endometrium is the lining of the uterus. So those type of cells grows on the outside of the uterus. That's what endometriosis is. And it's kind of this inflammatory process that over time can cause like scarring or adhesions and because that endometrial tissue is potentially growing like on the ovaries or in the ovaries, it can have an impact on your ovarian reserve, your egg quality, your egg quantity. Because of that inflammatory environment and the potential that it has on ovarian reserve, that's why we see an association with endometriosis and infertility. um, as far as how do you know if you have it or getting diagnosed, and kind of to April's point of how it gets missed so often or is underdiagnosed, or sometimes even overdiagnosed, is because the really the only way to diagnose endometriosis is with a laparoscopy. And so that is a surgery where they actually go in and use a laparoscope or like a camera through the abdomen, and then they can actually see that endometrial tissue or growth on the outside of the uterus. And so um, it unfortunately, that's a very invasive diagnostic test. So many women either don't know that they have it, or the diagnosis is just kind of presumed. Probably the most common sign of endometriosis is painful periods, and often what I would consider like primary dysmenorrhea or primary painful periods, where like you as a teenager, as or a young adult, your periods are painful. And then often sometimes you'll see like some bowel changes with your periods. That's another big sign of endometriosis. And so often just having that symptom or experiencing those changes, women will get diagnosed with endometriosis. It it sometimes, with endometriosis and the impact that it has on fertility, it's tricky because the way to treat endometriosis generally is not conducive to pregnancy or fertility, right? The way that they treat endometriosis is by suppressing the ovaries, and in order to conceive, we can't have the ovaries suppressed. So it definitely is challenging.
Well, we're almost to time. So thank you so much, Jesse, for handling all of these questions. Thank everyone for submitting their questions, and I really hope that this was helpful. I think what we're trying to do here at Hera is really empower couples in their fertility journey to be able to make the right decisions and have all of the information that they need. So if you guys need anything at all, we will have a follow-up email that will contain a link on how you can schedule an appointment and reach out to us with anything, because we really just want to help in any way we can to support you in your fertility journey. So thank you all for being here today, and we'll see you next time.
Yes. Thank you.
Bye.
Bye-bye.